So the second panel will be focusing on clinical perspectives, and we're delighted to introduce Alan Ducatman, who's an MD, MS. He is a Mayo Clinic trained internist and occupational physician, currently professor emeritus in the West Virginia University School of Public Health. And School of Medicine. His clinical career has focused on medical screening, and his research focuses on environmental disease and disease prevention, including health communications to affected populations. He has designed community studies and published actively concerning population aspects of exposure to perfluoroalkyl substances, and many of the more than 30 publications are highly cited. He is a clinical consultant to industry, labor, nonprofit organizations, and government organizations. Dr. Ducatman also has worked actively with a variety of community groups to provide information concerning PFAS clinical science. In addition, he has an active research program in quality assurance concerning clinician laboratory orders and interpretation, which informs his community service. Other public service has included chair of the External Science Advising Committee to the National Center for Environmental Health and the Agency for Toxic Substances and Disease Registry of the U.S. Centers for Disease Control and Prevention. Dr. Ducatman.
Thank you for that kind introduction and for the opportunity to be with you today. The goals of this talk are listed here. I hope I'm coming through clearly. And all of the goals really relate to the intersection of clinical evidence-based science with the art of clinician-patient health communications. Because I don't have sufficient time to go through all the nuances, there's more information intended to be on the PowerPoints than I'll be able to cover verbally. And I hope that interested panel members will feel free to get back to me if they want to reference or have a concern about any of the talks. Clinicians make declarations, and in addition to my background, going back to the C8, the creation of the C8 Health Project, where I was a clinical consultant even before the project existed and helped to create it. I also have some background in the U.S. Navy with two populations that were heavily exposed to PFAS and some health outcomes in that regard. And I should explicitly say that both as a volunteer and as a paid consultant, I've worked with communities who are seeking medical screening. The usual rules for environmental health toxicity and health communications are listed here. And they're pretty much the same for affected communities and providers. Open and honest communication, delineate who is the community that we're talking to. Is it a background exposure or a community more at risk because of heavy exposure, such as an occupational population or water contamination? And for clinicians, those rules again apply. And in addition, we talk more to clinicians about the cascade of risks and benefits that follow from any medical screening. So there's a little bit more about that with the clinicians. And most of these considerations are really about things that are reasonably objective. They're not about feelings. They're about things that we can quantify or at least qualify to some degree. Now, when we make those health communications, provided they're formal and official, we think of them in the context of the patient-clinician interface shown in a theoretical Venn diagram at right. But the reality is that those same communications have much broader ripple effects across other communities who are also reading those communications, including water managers and small town managers, mayors, state officials, and others, all of whom have limited budgets and who are seeking nuances of our communications in order to figure out whether or not they should be safeguarding or using those limited budgets on behalf of some public health need. So I don't want us to think that our communications between the topic for this committee, patient-clinician communications is going to, and screening is going to be limited in any way to the intended community. It will be read by a broader community. Now, it turns out that ATSDR has formal, internal, publicly available criteria for that, which Dean Baker in many ways already summarized nicely. And I'm going to summarize it again using some other direct quotations. And those are from 1995. They're in the Code of Federal Regulations. So that's pretty formal. And they talk, first of all, about what is the community at risk. And mind you, this now is very clearly not about background exposure. So this gets to that topic of intellectual fairness. We're now talking about a small subset of all the world, the millions rather than the billions, the millions who are heavily exposed rather than the billions who are exposed. And an exposure will be considered sufficient for screening in that population if there is some level that's, they use a fairly liberal definition. They give several examples, including even RFD thresholds, which are fairly liberal and low. But you can use several different ones, and they give an example in the Code of Federal Regulations. And then they switch to outcome. And for outcome, they give very useful guidance about biomarker, excuse me, I'm still with exposure, I apologize, about how to quantify that exposure. And they say that it can be environmental measures, exposure models, or population biomarkers. And they make clear that it's not necessary to have internal biomarkers in the entire exposure population in order to recommend or not recommend screening for that population. Now, a possible implication of that is that you don't need to get biomarkers for everybody. However, the experience for anybody who's been a clinician taking care of the high exposure populations, messages such as you don't need to know, it won't help you, or the even more common, you are better off not knowing because you'll worry message, those are predicted, those could have been predicted not to work. They don't work in present and they won't work in future. They're just not good examples of the art of health communication. So currently, I'm going to mention that if we think about this need, the actual need for screening being in those high exposure communities, we have to consider it. It's actually, in contrast to what one of our speakers said, it's actually far easier to do the screening in that setting because there are ways to get resources. There are ways to consolidate the activity. There are ways to find just a few local clinicians who want to participate in this difficult topic, who then can become more expert in it. And I think it works much better if we consider the reality of who is the target for these communications being the high exposure communities. So I want to reiterate, who is the communication for? In most cases, although these communications appear to have been designed for the entire world, they are getting directed at the high exposure communities. And that conflation of who the communication is intended for has been an ongoing source of tremendous frustration for the exposure communities. And I think the committee has already heard about that. And I think it will have the means to address and resolve that problem about who are we speaking to. Now, when the patient does come to your office, what are their health concerns? Or when the community leader is talking with a clinician leader who's related to the community, I've listed the things I've heard the most about on the left: cancer, infertility, transgenerational exposure, human development outcomes, including birth defects and developmental delays, and stress, including stress on property value, the stress of maintaining filtration equipment for people who don't really know how to do it and how complicated that can be, the guilt concerning children or family. And I want to emphasize something about that. In the high exposure communities, the idea that testing is going to further decrease your property value, that horse already left the barn. It left it long ago. People want to know their internal contamination level without additional fear that it will further decrease their already greatly diminished property values. So I think we need to be clear that we're talking to the communities where we know they've been exposed. And what they want from us is broader and generally reasonable. They want our help to influence getting better water sources, or failing that, getting filtration. They want our honest opinion about breastfeeding or else delaying pregnancy. And they almost know we're going to say how wonderful breastfeeding is and all the advantages, but they also want us to be honest that we don't know for sure how much the PFAS damage is, and we don't really know for sure where that cutoff is. And we can be honest about that, and it improves the communication. They want us to decrease their risk by screening for both exposure and for outcomes. And they also fairly frequently, and I had another one already this week, they want to know how to remove the internal contamination, to which the answer is actually, technically, yes, we can. There are 3 different ways to do it. There's a clinical trial in Australia for what I think is the second best way, which is serial phlebotomy. There's also a fairly safe and standard old medication that does it really quite well for the sulfonates. But that doesn't mean that we know we should. I think it's an individual patient-clinician interaction. And I think the answer is usually not. But however, we heard Dean Baker say correctly that those average half-lives don't really speak to what happens necessarily at the individual level. And there may be exceptions where we do want to consider it because of the stress of the ongoing high levels. And of course, they want us to influence entities perceived as unscientific or uncaring. And I want us to emphasize unscientific because the communities are aware, their opinion is strong that some of the current communications are not just poorly crafted, they're unscientific. So the ATSDR framing now for the health outcomes is put in terms of what is the level of evidence, which they say is a reasonable association between an exposure to a hazardous substance and the specific adverse health effect or biological marker or effect. So biological markers are clearly in play, and they want ATSDR, again, in the Code of Federal Regulations, is also communicating. Of course, it's not enough to have that marker if you want to really help. It's also important that that marker or that early detection, whatever it is, be directed at something that usefully improves the prognosis, improves the quality of life, or interacts with primary prevention. So in the Code of Federal Regulations, it's fairly clear that primary, secondary, and tertiary prevention are all at play in these health communications. It's not just whether or not we're going to use a pharmaceutical agent, although that is also part of this consideration. It's not just whether we're going to do a more extensive workup, although that's certainly part of this communication. It's all phases of prevention. And also they state very clearly that biomarkers of disease processes, if they're altered, are sufficient reason for the consideration. We don't always have to have ICD-9 codable outcomes, although it's also clear that we have plenty of those. So here we are where evidence-based medicine now meets those health communication sort of principles. And I thought Dr. Samet gave us both a wonderful word and a wonderful talk about how we might think about that. I think the word equipoise is much nicer than the clinician Hill criteria-based discussion of what is or isn't more likely than not. So I'll stick with equipoise from here on in. I really like that. And I personally, for myself, divide things that are above equipoise into barely above on the right or well above in the middle, and very substantial and extremely unlikely to be overturned on the left based on the amount of evidence in either population or experimental or both kinds of evidence. And here, just me to you is where I today put those things. And if I change the things in the middle 2 columns tomorrow, I don't feel the least bit bad about that, because this is, in fact, as Dr. Baker pointed out, an evolving literature. But we have lots of outcomes now that a reasonable person can consider above equipoise. It's moved on from the excellent work done by the science panel from the data in the C8 Health Project. And there are more outcomes now than then, just as you would expect. And he implied that, and I'm going to state that clearly. On the other hand, there are some where the evidence may be a little less clear, such as thyroid disease. It's still above equipoise, but it now looks like we should be most concerned in specific subpopulations. So that population evidence informs the discussion. Just for clarity, I'm going to point out that for lipids, it's now around 25 different populations with all kinds of different study designs, including longitudinal diagnoses that follow the need for increased treatment that we can see in these populations. And there are also studies that estimate the strength of the relationship, and there are studies that show that the dose response is repeatable, provided that it's a large population with a wide range of exposures. For liver functions, it's about half that many populations. For uric acid, it's about a third that many. And for insulin resistance, it's almost that many, but there is more variability in the findings. It's a harder topic to study for a lot of reasons. Now, we frequently discuss bias, even when there's lots of data. And we need to point out, of course, to ourselves that bias is a two-way street. There's systemic underestimation as well as overestimation. And I'm going to point out that in so far since the science panel made its initial studies and deliberations, in 15 years of increasingly intense research for the lipid, liver, uric acid outcomes, we haven't yet found any plausible or reasonable competing bias explanation for those outcomes. They look to be pretty solid. And there are multiple pathways. It's not a dearth of pathways. There are multiple pathways in play from experimental data. Now, to further enlarge on that point about that Dr. Baker made about the literature moving on, the science panel indicated kidney cancer, but not kidney disease. We now have 3 review studies with increasing evidence suggesting that kidney disease is a above or more likely than not outcome, above equipoise or more likely than not outcome of PFAS exposure. And that's just an example of many. And this doesn't even get into all the outcomes that are increasing that may have increasing experimental evidence, but are not yet, in my view, at equipoise. Now, it also helps to look at these things with a clinical synthesis kind of an eye, because if we think about the animal or the toxicological data about lipid droplets and hepatocytes, enlarged hepatocytes and heavier livers across species, so far as I know, every time this has been measured in a species, the outcome has been found. If there are exceptions, I don't know about them. And then we think, well, if we wanted to think about what that would mean, if we were also going to be actually doing liver biopsies in humans and discussing, steatosis in humans, which is what that is, the first stage of non-alcoholic fatty liver disease, we would be considering things like lipids and elevated liver functions and higher uric acid and insulin resistance and disruption of insulin signaling. So when you look at these things with a clinical eye, you can say, oh boy, that is not inconsistent. That is not everything and anything, which I heard one of the people who address you say in a previous meeting. That is sort of the clinical synthesis, the way Hill asked us to look at it, which is to say the experimental evidence and the human evidence look fairly convergent. Now, that doesn't mean that we need to provide alarm to patients who aren't concerned. Patients who aren't concerned are generally those who don't live in those high exposure communities. They're generally not in our office asking questions. And if they are the patient, the extremely concerned patient, vulnerable to the non-standard clinician, it will certainly help us to have standard recommendations in future rather than the current situation where we have no reasonable recommendations that have been provided before the PFAS REACH documents and a few others that have been out there. So I think that while we are never going to get to perfect, we can improve that vulnerable patient situation, not by sticking our head in the sands, but by providing the reasonable guidance that we hope will come from this committee. In addition, we know from the C8 Health Project, so that's tens of thousands of people with 81% participation rate, and then a much smaller random sample of it, the people, that random sample found that they really appreciated getting both their serum PFAS levels and their clinical data back. And it would surprise me if there's any community in which the feedback would be different. People who want to participate value that level of participation. Now, there's a couple of other things that we rarely talk about in that ATSDR guidance, and these are the system recommendations. And there's probably reasons why they're not even discussed, but I don't know what those reasons are. And they have to do with the importance of local input. So once we decide that we're going to consider that there should be screening, we really need to get both community and local clinician input as to what's reasonable in this community. And then there should also clearly in ATSDR guidance to itself in the Federal Register be some mechanism for annual report back, or at least some periodic report back. How many participated? To some degree, what's being seen? Is there some mechanism for quality improvement? These are things that Dean Baker alluded to, but I want to state them clearly. These are things that ATSDR and its guidance to itself says are important, and they're right. And they're frequently overlooked, and we can do better. So what are the lessons learned? I think that a lot of the ambiguity can be addressed just by making a clear distinction between whether we're making a guidance document for the entire world, for all, however many billion of us who have PFAS in us, versus the millions of us who are going to have very high levels because we're in an occupational group or our water is contaminated. Most of the activity related to this committee's concerns will be in that latter, smaller group. And it's important that we make our communications, some of those communications directed specifically to them. And it's also important that we distinguish the levels of evidence. Documents that say may cause disease and then don't say what disease or what the levels of evidence are not helpful. Documents that say some papers, when in fact we have 25 populations and hundreds of papers, are more than not helpful. They're deceptive. So we need to be thoughtful about how we write things, who we write them for, and what we say. And finally, it's really good to provide really supportive advice consistent with the reason for patient concerns. These become teachable moments. Clinicians already know that patients have multiple risk factors. That's not a surprise to them. I don't know a clinician who thinks that PFAS is the only thing in the patient's personal environment from either social or environmental stressors. But that doesn't make this kind of, I'm now quoting directly from a prominent current communication to the patient. If you are concerned, see your doctor. That's pretty standard. Although I have a lot of problems with the if you are concerned, if this is directed to a heavily contaminated community. I think that needs rethought. And then here are the two things the clinician is given that they might be able to say to the patient. Type A is, we don't really know if the PFAS caused your illness or made it worse. And type B is, there is no reason to think the PFAS caused your illness or made it worse. Now, please think about that in terms of the reasons the patients came to see us in the first place. Suppose this were asthma and it weren't about PFAS, and we said to the patient, we can't treat your asthma because we don't really know all the things in your environment and all your risk factors, so we're going to give up on asthma. That would be incredibly silly. Instead, we work up the asthma, we try to find the environmental stressors, we acknowledge we don't find them all, and we still go ahead and try to do primary, secondary, and tertiary prevention. It's prevention, not post hoc causation, that is the primary reason the patients come to see us. And if it were post hoc causation that were their concern, clinicians and even patients understand pretty well the difference between increased risk and the more difficult semi-legal topic of assignment. And if it were that semi-legal topic that was of concern to public health agencies, well, their current guidance is not actually consistent with what's happening in social settings. So if it's followed, it could put the clinician in conflict with the patient's best interests. So I think there's a lot of reasons that these current messages, which say no matter what direction you come from, you should stop, can be improved without a lot of effort. There's a lot of hard things to do, but improvement will be easy. Clinicians get algorithms. Clinicians get increased risk. Clinicians understand multiple comorbid risk factors, and they use them as teachable moments, and they don't need to use them as reasons to dismiss the patient from their office. What clinicians don't get is time, and what they do need is support to do exactly what's already been implied. That's so that there's fiscal support for counseling, so the patient and clinician can have a reasonable discussion. And then that there are brief, targeted, reasonable, and not way off the point messages as we currently have today. So those do need to consider benefits and harms, but they also need to be short. And we need to remember that evidence gaps are a two-way street. When we recommend breastfeeding, which is a good thing to do, that's also in the context of considerable uncertainty. So has already been mentioned, the PFAS REACH documents are very simple rubrics for very substantial improvement, but they're not the only ones. ASTO, the public health officials, when they retreat to their personal public health organization, they have really good documents about weights of evidence and PFAS health outcomes.
Did we lose Alan?
Looks like he might have froze.
Oh,
Oh,
okay. Maybe what I'll do is go ahead and introduce the panel. Does that sound good, Ned?
Yeah, I think that's a great idea. Thank you.
Yeah, I think he was almost done. So